Va.
Bienvenidos una vez más a este 11º webinario del año 2022 que se hace con el objetivo de poder mejorar nuestros conocimientos y nuestra experiencia en el manejo de la vida aérea. Aquí tenemos un problema. No sé cómo retroceder. Sí. Este webinario está organizado por el programa de Anestesiología y Reanimación de la Universidad Diego Portales, que tiene como objeto lograr formar un especialista capaz de ejercer la anestesiología en forma integral, entregando al paciente una atención acorde con la evolución de la especialidad, adaptándose a los cambios epidemiológicos y al desarrollo de la tecnología. El programa de anestesiología de la Universidad Diego Portales es dirigido por el doctor Ricardo Latrop Allende, quien nos acompaña en este momento. Este webinario también está apoyado por la Sociedad Europea de Vía Aérea, la European Airway Management Society, y por la Sociedad Española de Anestesiología, Reanimación y Terapéutica del Dolor. La Hemos es una sociedad orientada hacia el manejo de la vía aérea que agrupa a todos los países de Europa, incluido y excepto también el Reino Unido, que tiene su propia sociedad desde muchos años, la Difficult Airway Society, la DAS, y también es hermana de la Sociedad Americana Vía Aérea, la SAM. Pueden ustedes visitar el sitio web de la EAMS en este sitio web que les estoy mostrando en este momento. En el Latinoamérica, la EAMS tiene dos representaciones, una en Argentina y otra en Chile, en Argentina liderada por la doctora Paula Chiesa. Los invito a hacerse miembros de la EAMS, para los cuales ustedes pueden, en el mismo sitio web, pueden encontrar la manera de hacerse socios. Nuestros países de Latinoamérica tienen un descuento especial, lo mismo los residentes, estudiantes, no académicos y también no médicos de cualquier país tienen un descuento especial para la membresía que dura todo el año. Hay diferentes beneficios, como ustedes pueden ver, incluyendo la suscripción online a la revista Advanced Anesthesia and Critical Care. En el código QR ustedes pueden automáticamente dirigirse hacia este enlace. Este año, 2022, hemos tenido una constelación de brillantes invitados durante todo el año que nos han aportado muchísimo sus conocimientos, a nuestro bagaje, para poder ofrecer a nuestros pacientes el mejor nivel de calidad y seguridad en el manejo de... les agradecemos a todos los que durante este año nos han acompañado. Ya estamos llegando al final del año, el próximo mes tenemos el último webinario antes de proseguir con el programa del año 2023, que se los presentaré oportunamente. Aquí ustedes pueden ver todos los temas que hemos revisado durante el año y que han sido temas extraordinariamente importantes que nos han aportado muchísimos conceptos a nuestro manejo. Este webinario es traducido a 3 idiomas, al portugués, al inglés y al español, gracias a la empresa Traducciones Remotas, que nos acompaña en este momento y nos ha acompañado durante todo el año, permitiendo que invitados de hablas extranjeras, como el Dr. Cook en este minuto, puedan ser comprendidos por nuestra audiencia. Los invitamos, como siempre, a participar, ya sea escribiendo a través del chat. Por favor, pongan sus nombres reales para poder identificarlos y poder presentarlos adecuadamente. También pueden levantar la mano en la herramienta que hay abajo de sus pantallas de reacciones. Pueden levantar la mano y les ofreceremos la palabra en el momento en que sea oportuno. En este momento quiero presentarles al profesor Tim Cook. Él es consultor en anestesia y medicina de cuidados intensivos en el Royal United Hospital, NHS Trust, en la ciudad de Bath, Inglaterra. Es profesor honorario de anestesia en la Universidad de Bristol, es asesor universitario en manejo de la vía aérea, es director de los proyectos de auditoría nacional, mejor conocidos como los estudios NAP, y con relación a estos estudios, el profesor Cook ha estado involucrado completamente en 5 de los 7 estudios que se han hecho del Colegio Real de Anestesistas, los cuales han cubierto las principales complicaciones relacionadas con la anestesia. Recordemos que el NAP3 se relacionaba con anestesia espinal y epidural, NAP4 sobre el manejo de la vía aérea, que ha sido tenía un tremendo impacto en todo el mundo, el NAP5 sobre la coincidencia accidental, el awareness, la conciencia, perdón, accidental awareness durante la anestesia general, el NAP6 sobre anafilaxia perioperatoria, NAP7 sobre el paro cardíaco perioperatorio, publicado recientemente el año pasado. Estos tremendos proyectos han involucrado a anestesiólogos de todo el Reino Unido para dar luz a aspectos de la práctica anestésica y seguridad centrados en el paciente. Estos estudios son una forma de ciencia profesional ciudadana, significando esto una participación activa y voluntaria de la ciudadanía en una investigación científica, que han sido reconocidos y han cambiado el panorama de la práctica anestésica clínica y el compromiso de la investigación en anestesia. Durante la pandemia estuvo involucrado directamente en el análisis del examen sobre vida de pacientes desde su ingreso a cuidados críticos, la seguridad del personal sanitario, el manejo de la vía aérea en este contexto y la ciencia de la aerosolización y su interacción con la seguridad del personal. El profesor Cook también ha tenido un destacadísimo trabajo editorial, pues él publica constantemente importantes artículos y libros que han contribuido a mejorar el conocimiento y su aplicación, especialmente en el manejo de la vía aérea. Muestra de su compromiso académico destacan sus membresías como que es miembro del Consejo Editorial de la revista Perioperative Medicine desde el año 2011 y también es editor asociado del British Journal of Anesthesia del año 2011 también. Toda esta labor continua del profesor Cook ha sido, por supuesto, reconocida a través de al menos dos distinciones. Una es la medalla Humphrey Davy del Real Colegio de Anestesistas el año 2008, y dos, el certificado Fiddlestone de la Asociación de Anestesia de Gran Bretaña e Irlanda en 2011. Recientemente, el profesor Cook ha sido nombrado miembro honorario de la Hemos. Finalmente, quiero destacar que el profesor Cook ha sido un gran impulsor de muchas iniciativas que han contribuido a mejorar la calidad y la seguridad del manejo de la vía aérea en todo el mundo, por lo que su participación en este webinario es de gran relevancia para los anestesiólogos de América Latina. Para mí es un gran honor presentarles y dar la bienvenida al profesor Tim Cook. Muchas gracias.
Hello, I will now, Ricardo, thank you very much indeed. I will just share my screen. I think I need to be allowed. I can't share my screen at the moment. So I'm just waiting to be allowed to share. Okay, I can share my screen now.
Empecemos con las preguntas.
I'm sharing my screen and... Okay.
Empecemos con las ¿te parece?
Okay.
Preguntas. Empecemos con las preguntas primero. Estas son preguntas enviadas por el doctor Cook para nosotros y queremos que ustedes las respondan. La primera es, ¿cree que el manejo de la vía aérea se ha hecho más seguro en la última década? Ahí tenemos preguntas, las respuestas. Y hasta el momento parece ser unánime que todos los participantes creen que el manejo de la vía aérea ha sido más seguro en la última década. ¿Estamos bien, parece? Tim, parece que es unánime. Todo el mundo cree que en la última década hemos tenido mayor seguridad en el manejo de la vía aérea. Veamos la segunda. La segunda pregunta. Ahí está la segunda pregunta. ¿Cuál creo que son los principales elementos que la han hecho más segura? Aquí les pedimos que por favor nos den su opinión a través del chat. Y entonces le transmitimos al Dr. Cook y va a ser posiblemente materia de discusión posteriormente, durante la charla y después de la charla. Eso. Finalizamos la votación. Les rogamos que nos den sus respuestas a través del chat, de tal manera de poder utilizar estas respuestas para la discusión posterior a la charla. Tim, ¿tienes la palabra?
Okay, I hope you can see my slides.
Oh.
Can you confirm you can hear my slides and see me? Good, okay. Firstly, Ricardo, thank you very much for the invitation. It's a great pleasure to join you. I've put on my title slide that I'm speaking to Chile, from Chile. I'm obviously not in Chile, and I know that people will be joining the webinar from places other than Chile. I'm probably going to spend about 50 minutes talking through really two topics, trying to address whether after NAP 4, now published 11 years ago, we've made any improvements in airway management, and hinting at the fact we could do more, which I think those two questions suggested. And secondly, talking about a specific problem, esophageal intubation, or rather unrecognized esophageal intubation, which is an area of particular interest and particular concern at the moment. So at the top, you can see where I come from. I work in a district general community hospital in the southwest of England called Royal United Hospitals, Bath. And I have an honorary chair at the University of Bristol. And as Ricardo said, I've been involved in the national audit projects. I don't really have any conflicts in doing research over the last 2 decades. My department has been provided with some equipment to undertake that research or to evaluate. That's been provided at cost or free for my department on some occasions, and I sit on some working parties. I have borrowed some slides from those who are wiser, better, younger, and clever at making slides than I am for this meeting. The picture is the church in the centre of town where I live. Bath's a very beautiful city, and that's the illuminated abbey. So I should say also that none of the national audit projects from which I gain most of my information could be done without support from my colleagues in the hospital I work in, but particularly by all the anaesthetists that contribute to the project. It is a national endeavour to undertake all of these national projects, and it's on their shoulders that I stand when I speak. So we go back to NAP 4. These are the questions we really did not know. We didn't know the answers in the UK, and perhaps as a measure for some other countries. We didn't know how many anaesthetics were given. We didn't know who was harmed by airway management, what those problems, who or what the problems were and where they occurred, whether the patients recovered. We didn't really know what to tell patients, and we didn't know how to prioritise for improvement. It's impossible to summarise the findings of a 160, 180-page document in a few slides. But we noticed, just going through these things in turn, that while assessment was commonly undertaken, the findings from assessment were often not acted on. And although we only looked at events where things had, as it were, gone wrong, where there had been complications, we didn't learn from good practice. We did note that when things went wrong, then there had been perhaps predictors at assessment. So sometimes the plan or the strategy for airway management was not changed in the light of the findings at assessment. And that's a key message, that if you find signals of risk or potential difficulty at assessment, those should be acted on to reduce the chance of a patient coming to harm. Secondly, we found that people often had a plan. They said, I'm going to do this for airway management. What they didn't say is, I'm going to do this, and if I run into this particular problem, I'll change to this, and if that doesn't work, I'll change to that, and if that doesn't work, I'll do this. And these are the triggers that will make me change from A to B to C to D, and these are the actions I will take. And we can compare there the single plan to the strategy with each subsequent plan contingent on the failure of the first plan. And that is more like a Difficult Airway Society algorithm for what we would do. That needs to be created for all patients. It needs to be communicated to the airway team. We found that aspiration was the commonest cause of fatality and brain damage during anesthesia in terms of airway management, and that was something of a surprise. We found that about 40% of the cases reported in anesthesia related to head and neck surgery. Not a huge surprise, but perhaps the extent of that was surprising. And again, we found that senior anaesthetists ignored predictors of difficult airways, ignored the fact that a junior had had difficulty with an airway, and sometimes just did what they normally did because that was their pattern of behaviour, rather than changing their behaviour according to the needs of the patient. And the obstructed airway within those head and neck cases was hugely important. In NAT4, so this was 11 years ago, slightly more than half of general anaesthetics in the UK were undertaken with supraglottic airways, the vast majority first generation, so standard simple tube supraglottic airways. These were, some failures led to major complications. Particularly this occurred in obese patients, and particularly it occurred at the hands of rather junior anaesthetists. And the problem seemed to be particularly that individuals would accept a poor quality airway and continue with it. And then subsequently, during the middle of the case, or especially at the end, problems would occur. There was a problem of what I would call perseveration, or repeated attempts at intubation. If something hasn't worked, doing it again and again is unlikely to work again. Doing the same thing again and expecting a different result is a definition of madness, as Einstein probably didn't say. And we found 5, 6, 7 attempts at intubation without a change in strategy or plan, leading to further complications. We found an absence of capnography, and we commented particularly in intensive care that the failure to use capnography or correctly interpret it was contributed to about 60% of the deaths in intensive care. At the time, capnography was used for about 50% of intubations and in less than 50% of ventilated patients in the UK. I'm pleased to say it's now used as a standard of care throughout the UK. We found high rates of failure and difficulty when patients had can't intubate, can't oxygenate situations, and almost all attempts to rescue the airway by anaesthetists with narrow bore cannula failed. They were almost all successful when undertaken with wide bore cannulas by surgeons, and that's led some to conclude that narrow bore cannulas are bad and wide bore tracheostomies are good. But that's not something we conclude from NAT4, because the cases that the surgeons did, they were usually ENT cases with an ENT surgeon there, where the anaesthetist was able to continue managing the airway while the surgeon took over the airway, often taking up to 30 minutes to secure the airway, but the oxygenation was maintained by the anaesthetist. Whereas those patients where the anaesthetist took over were often in extremis or even effectively post-mortem. So when someone had gone into cardiac arrest and the airway had to be abandoned while the anaesthetist attempted a front of neck airway. So we don't have a clear comparison of the two. And one of the projects that in the UK we aim to do in the next few years is to explore that further. Obesity was a major problem with the obese and the super obese disproportionately represented in all complications, as they have in all the national audit projects. And I think the difficulty there is not so much in difficult laryngoscopy, difficult intubation, but specifically the issue of a short safe apneic time. So I think always be respectful and cautious of the physiology of patients who are obese. A quarter of events occurred during extubation, and they were particularly associated with bleeding and airway obstruction, often out of hours. And also roughly a quarter of the events took place in ITU, while only perhaps a tenth of anaesthetics took place in ITU. Intensive care and the emergency department were areas associated with an increased incidence, increased prevalence of major airway complications. And they were associated with gaps in care to a greater extent than anaesthesia. So if you had an airway event meeting the NAP4 criteria, which were an event leading to a front of neck airway or intensive care admission or death or brain damage, if you had one of those occurring in anaesthesia, then 14% of patients died. And if that occurred in intensive care, 60% of patients died. So the airways may be more complicated, but the organizational, the preparation to care for patients was poor. And this applied similarly, but less so to the emergency department. And finally, and I'm sorry that it's finally, issues of communication, human factors, and performance behavior under stress were important. So that's where we refocused. It's worth mentioning that in airway management, everything fails. If this was an industrial process and we had failure rates of even 2 to 3%, but of 5%, of 25%, of 60% with FONA, we would not be running a business. Also important to mention that if your patient has difficult laryngoscopy, they are more likely to have difficult mask ventilation. And if they have difficult mask ventilation, they're more likely to have difficult laryngoscopy. So the patients that have one difficulty are more likely to have another, what I call a composite failure or composite difficulty. So did we change practice of airway management as a result of NAP4? Well, 3 years after the project, we set out to examine that with a national survey, with about half the country responding to it. And we examined whether there had been changes. So we can see that in blue, we have an airway lead in every hospital in the country, and we asked the airway leads whether their practice had changed, and we asked the airway leads whether the departmental practice has changed. And as you can see, considerably more than half departments practice changed a lot. And we asked the question, did things change as a result of NAP4, not just over time, but as a direct result of NAP4? And you'll see that there was a lot of change, both individually and departmentally. We looked into that in more detail. So we picked out the most important recommendations. So for instance, here we have at the left, immediate access to difficult airway trolley. And what we said was, where were you before NAP4 in terms of access to an airway trolley, and where were you after NAP4? So we worked out what the safety gap was between NAP4 and what it was afterwards. So we assumed that adherence to our recommendations would mean 100% safety. And we worked out how much the gap between adherence before NAP4 and after NAP4 had closed. And we found that the gap sometimes changed by 80%, sometimes by 50%. But overall, in ITU, where there was the greatest need for change, the safety gap changed as a result of NAP4 by about 60%. And in anesthesia by 50%, in ED by about 60%. So what has changed in the last 10 years? There are more video laryngoscopes, there's more use of second generation supraglottic. And what I would say is I work in the UK, I know the UK, I know Europe a bit, I don't know South America and South American practice. So forgive me if what I say doesn't translate to South American practice, and bear with me in terms of that context. But I think particularly with the pandemic, we've seen more video laryngoscopy. Certainly in Europe, we've seen more use, and now predominant use of second generation supraglottic airways. We've definitely seen more high flow nasal oxygen, more oxygenation that occurs during anesthesia as opposed to occurring before and after. And I think we've seen an improvement in care and intensive care. And one of the features of that has been, a lot of that I think has been driven by NAP4 in the UK. We've seen heightened awareness of the dangers of anaesthetising patients outside theatres, be it ITU, the emergency department, or remote locations within our hospital. And I hope we have better training. So there is a question, have we reached peak airway? Have we done it all? Do we not need to change anything? I think to work in optimal conditions, we all need to be trained, we need to be up to date. Very important that we work as a team, that no one succeeds by themselves. And we need what I call organizational preparedness and personal preparedness, which I'll come back to later when I talk about esophageal intubation. And this, in simple practical terms, my simple practice now is to oxygenate at all times, to use a video laryngoscope, to use a second generation supraglottic airway routinely, and to try and understand and practice crisis management so that care improves when unlikely complications occur. As a nation, as a country, have we learned from NAP4? Well, I think a lot of the lessons from NAP4 were embedded in the 2015 revision of the DAS guidelines, which I wasn't involved with. But I think it lent on, so Chris Frerk, who was and Anil Patel, Ellen Sullivan, Nick Woodall, who were all centrally part of NAP4, were involved in writing those guidelines. And so here we see that strategy, the ABCD. We see the greater emphasis on second generation supraglottic airways. We see the emphasis on limited attempts. We see good human factors practice, waking up if there's a problem and we've got to a safe place. We see a change in practice, a change in emphasis on how front of neck airway should be achieved, emphasizing a wide bore tube as opposed to scalpel bougie tube rather than a fine bore airway. And we see overall a strategy, an A, a B, a C, and a D. And I'm a simple man, I can only remember 4 things. So airway management, A, B, C, D, that's usually good enough for me. And it's good enough for me to communicate with my team. If we look at the airway equipment, so in the more in-depth algorithm, the rescue equipment when airway management is difficult in the DAS guidelines is video laryngoscopy. So whatever you started with your laryngoscopy, video laryngoscopy, move to video laryngoscopy. If that fails, whatever you started with in terms of supraglottic, move to second generation supraglottic. My personal favorite is the ProSeal. And if that fails, move to a front of neck airway. And we've seen more guidelines since then. Each guideline has further emphasized good communication, good human factors, increased use of video laryngoscopy, further emphasized second generation supraglottic airways, further emphasized not persevering with repeated attempts at anything. And I'd mention here the vortex from Nick Crimes, the vortex, which tells us that we should never be doing anything more than 3 times before we move on to a different technique. And then, of course, with the COVID pandemic, further emphases. So in the hospital I work in, we use video laryngoscopy all the time. So if we have a difficult laryngoscopy, we've already used the optimal device. If we can't intubate, well, the only supraglottics we have apart from for head and neck work are ProSeals and iGel, second generation supraglottic airways. So we use those routinely. So our difficult airway equipment is in fact what you see on the right. It's just a size 6 tube, a bougie, and a scalpel. And actually, we have a size 6 tube and a bougie in every theatre airway trolley. So actually, the rescue equipment we have is a scalpel. That is our emergency airway equipment in Bath. The rest is routine. And that cuts through a lot of wasted time if there are problems. And also, it means people are familiar with these devices. They're familiar with the techniques and the use of these devices. They're made more familiar because we train everybody in the department. this is being taught here is an anaesthetist who also happens to be the medical director, so he's the doctor in charge of the hospital, and he is a senior anaesthetist, and he is attending one of our airway workshops, and he may be taught by a junior anaesthetist, or he may choose to teach in one of the workshops. And we teach not just our department, the anaesthetists, but the ENT surgeons join us, the emergency department doctors see us, and all the staff who help during intubation and airway management join us. So we try and train as teams, sometimes with many hands managing the airway. And I think this is one of my favorite quotes. I've used it in lectures for probably 20 years. We are what we repeatedly do. Excellence is not an act, but a habit. And I think if we're doing what is good practice routinely, what is safe practice, the techniques we might use for rescue airway management, then I think, firstly, we reduce the likelihood of complications, but also we are better able, both from an equipment and from a performance perspective, to manage difficulties. So has airway management become safer? This was the instance of major complications in NAP4. Remember, these are events which led to death, brain damage, front of neck airway, or admission to ITU. And if on ITU, a prolongation of ITU stay. And overall, about 1 in 22,000 cases. And I think we got the majority of cases from the UK. You'll see that events were more frequent with tracheal tubes than supraglottic airways or face mask ventilation. But of course, the more difficult cases are managed with a tracheal tube. There's several parallel studies of, or subsequent studies of airway management, which have tried to look at rates of complications. Huiting calls this the mini nap, and in this mini nap done in Holland, they looked at about 2,500 to 2,800 cases and looked at low risk complications, so hypoxia, changing the technique, as well as serious complications, and actually had a high rate of complications. So this was in a teaching hospital, which included head and neck airway management, but they had a 6% incidence of complications, including 1 in 3,000 of can't intubate, can't oxygenate, and airway-related death, which may have been just bad luck, but they did have that, and hats off to them for repeating it. A somewhat different study from Endlick in Australia, where they looked in 12 different tertiary hospitals in Australasia and New Zealand, and looked at complications which they defined in this way. So where the situation was not controlled, there was unexpected desaturation or unnecessary deviation from the initial airway management plan strategy. And they found a very different instance, not 6%, but they found 0.08%. But their complications were very differently defined. And then lastly here, I'm going to move on to what is my favorite airway study from last year. And I would recommend that everybody finds this study by Tina Pedersen and reads it. So they looked at major events during airway management, which they defined in the same way as NAP4 did. And they also looked at minor events, so all sorts of minor complications. And they collected data routinely and thoroughly for a period of 9 weeks. And then they made an intervention to try and make airway management safer. And then they looked again. And in the first period, they found a complication rate of 15%, so really quite high. But most of these were minor events. And I guess the thing we should think about is that minor events are precursors of major events. So a little bit of difficult mask ventilation might be the precursor of impossible mask ventilation. Their intervention was that they gave early muscle relaxants. So as soon as the patient was anesthetized, before bag mask ventilation, where muscle relaxation was indicated, they gave it early. They emphasized pre-oxygenation and they emphasized apneic oxygenation, but not high flow, just nasal oxygen at 2 to 4 liters per minute, which I'm a big fan of. They used a checklist and ensured there was a strategy that was communicated to the team. If there was difficulty, a senior took over very quickly, and they increased the use of video laryngoscopy. So that's increased use of early muscle relaxation, not increased use, but early muscle relaxation when it was being used, pre and per oxygenation, communication via a checklist, seniors to take over if it's difficult, and increased use of videolaryngoscopy. And they made sure that people understood what was going on. So they changed practice. And they reduced all complications by 25%. A significant difference. And you won't be able to read all these changes, but every single airway complication has been reduced. Every single one. And all by roughly 25 to 50%. So very significant and important reduction in complications. So we look at all those things. And the really important thing of note there is that very relatively simple changes in practice can improve the safety of airway management. So airway management starts with a relatively high rate of complications. Simple changes make it safer. Now, we don't know, because major events are so infrequent, we don't know whether it actually reduces major complications, but we can guess that it does. So if we look at the iceberg, what are we looking at? So NAT4, with the lowest instance, was looking at all of the country, all of several countries, but looking at right at the top of that iceberg. Whereas these other studies were looking at smaller fractions of the iceberg and at different levels. ENDLIC looking at high impact complications, but only at the top of the iceberg. And then Wheating and Pedersen looking at lesser complications, but in small cohorts. So let's look at two other papers before we start to move on to another topic. So this is another study again from the UK, from Oxford, from Alex Cumberworth and colleagues in Oxford. And they had, I think it was 4 hospitals within the Oxford region. And for a year, they tried to replicate NAT4. It wasn't really NAT4, to be honest. So they had all the complications of NAT4, but they only looked in theatre. They didn't look out of theatre. They didn't look in ITU or the emergency department. And they also included some other complications, such as airway management in the recovery area. So when they compared the complication rate and said it was similar to NAT4, I think that was slightly misleading. But in broad terms, if we remember that 1 in 22,000 rate of complications in NAT4, here we have an instance that was 1 in 14,000, actually higher, but they did include some other complication rates. 2 important messages here. So first, they predicted whether for each patient, they predicted whether they had they identified whether they had a predicted difficult airway. And in those who did, the incidence of airway complications was 1 in 300. It's 45 times more common than without predictors. So use the predictors, although we're not good at predicting airway difficulty, use them. And secondly, their airway management didn't vary much. So if patients had predicted difficult airway, they just banged on, they just cracked on, they just did the same thing. They didn't change their practice. So I wrote an editorial responding to that paper with Richard Armstrong, and really all that is said in it is what is said in the title, which is that to understand the safety of airway management requires measuring it, but to improve it requires action. So simply measuring 10 years after NAT4 the rate of airway management complications is of no merit, and there will be no change in safety unless you've acted on the findings of NAT4 and indeed acted to make things safer. So you can perhaps compare the actions in that study compared to what we've done in Bath, where we now try and make every airway management action safer. And I think this is echoed again by this analysis of 600 cases reported to the Difficult Airway Society database very recently in the UK, again, from Sajayan and colleagues from DAS. So it's notable that 20% of patients had already a previously known difficult airway, and 58% were anticipated to be difficult, so 42% weren't. And they had quite a high rate of significant complications. 11% a critical incident. More than 1 in 30 had to be woken up from anaesthesia. 1 in 30 had to go to ITU unplanned or prolonged, and 0.5% had a front of neck airway or a cardiac arrest event. So these are pretty big complications, most of which occurred out of hours. And again, if we look at the complications, again, remember there are about 600 patients in the cohort. So almost all of them had difficult laryngoscopy, almost all of them. And a significant proportion had this composite failure or composite difficulty. And what was done to these patients? Well, in the majority of cases, normal plans were undertaken. So probably what they were planning to do. Only in a very small minority were awake techniques used. So if you don't change your practice according to anticipated difficulty, if you don't change your practice overall to try and make things safer, then you're not going to make things safer. I'm going to skip through this. So I think what we had before NAT4 was the concept of the difficult airway as being anatomically difficult. And I think, I'll come back to that. So this is a case from 2015, a very sad case from 2015, which illustrates some of the failures of airway management and how we can do better. This is a lady who was 10 days postpartum. She had pneumonia and went to ITU and required intubation. There were 5 attempts at laryngoscopy. In all of them, they almost saw the cords, could almost intubate, but didn't quite. And there was increasing difficulty in ventilation, followed by hypoxemia, failed ventilation with a rescue classic LMA, declaration of cannot intubate, cannot oxygenate, a delay in undertaking front of neck airway, and she sadly died. And I think this is typical of one type of airway management failure, which is that it starts with a cannot intubate, can ventilate, and can almost intubate. So it's can almost intubate and can ventilate. So it's a tricky airway. It's not a difficult airway. And then after a period of 20 or 30 or 40 minutes of efforts to rescue the airway, it changes into a cannot intubate, cannot ventilate or oxygenate, and an airway crisis, and a pre-fatal situation, and sadly, in some cases, a fatal situation. So I've explained that in this diagram here, and some of the failures that can and do occur. We don't know how many of these patients actually have genuinely difficult airways. And much like that DAS analysis of difficult airways, the primary airway problem in NAT4, in about 40% of cases, started with a tube problem. So if a patient aspirated and then became hypoxic and couldn't be rescued with a supraglottic airway and then had a front of neck airway, then that would be down as aspiration as the primary airway problem. But actually, many of all the cases almost certainly ended up with difficulty in tracheal intubation at some point in NAT4. We go back to the case of 00, we see that there were 5 attempts at direct laryngoscopy. There was a video laryngoscopy in the corner of the room. It was not used for the first go because the individual involved didn't really like video laryngoscopes. And remember that view, they almost could intubate. Had they used a video laryngoscope, someone skilled in it, then perhaps that life would have been saved at that point. The crisis would have been averted. But everybody else assumed the video laryngoscope had already been used when they came to use a direct laryngoscope. It was never used. Classic LMA has a low seal pressure. It's the wrong device to rescue somebody who's got a low compliance, someone who's postpartum with pneumonia, requiring ventilation. Your chances of rescuing somebody with a classic LMA is very low indeed. It's the wrong device. And here there was a significant failure to undertake front of neck airway in a timely fashion while the intensive care team waited for an ENT team to arrive, and front of neck airway was attempted by a junior anaesthetist. All airway managers should be willing and able to undertake emergency front of neck airway. So I think we've moved on from believing that the difficult airway is purely anatomical to understanding physiological difficulty, particularly in ITU and the emergency department, understanding that there may be logistical difficulty. So if you're intubating someone in bright sunlight outside hospital, or if you're intubating somebody without an assistant, or if you're intubating somebody and they're collapsed on the floor, there may be logistical difficulties. And then lastly, educational difficulties. If you're inexperienced, or you're inexperienced in the technique you're using, or you're actually quite late in your career and you're not up to date with the newest techniques, then there may be educational difficulty. And I pose this question, at which end of the problem is the laryngoscope or the airway device? So anatomical difficulty and physiological difficulty lie with the patient. And those are things that we need to seek to control, to optimize. Whereas logistical difficulty and educational difficulty lie with an operator or the organization, an individual or an organization. And those are things that we should eliminate. In the second part of the talk, I'm going to talk about learning from and preventing unrecognized, although I can't spell it, esophageal intubation. Where's this tube? Is it in the esophagus? Is it in the cords? Can we just see the cords there? Is that in the esophagus? I'll tell you, it's in the esophagus. And if we look at that study from Pedersen in Switzerland, they had a roughly 1% rate of esophageal intubation during their cases. But it reduced with their changes. This is my dad, who died last year. God rest his soul. And he was a history teacher. And the only history that I know is that those who do not know their history are destined to repeat it, which has been said by many different people in different ways. And we must learn from the sad experiences from other people. So we go back to NAT4. 1 in 20 of the events reported to NAT4 were esophageal intubation. So there is no national, there's no international, there's no structured way, there's no registry of collecting esophageal intubations. But as I've become interested in this topic, I've learned that more and more and more of these cases are occurring. I only know about the tip of the iceberg. I know about cases from the UK. I know about some cases from Australia, from New Zealand, from South Africa. But I know they're happening everywhere. And if I'm only hearing about these cases from places where they have high rates of inquest, high public scrutiny and reporting in newspapers, which is where I hear from them, then it's likely that they're occurring in other places as well. But in NAT4, when we did a year's data collection on major complications, 5% of our events were esophageal intubation. They occurred in all locations. They occurred in anesthesia, roughly in 1 in a million cases, and outside the operating theatre, probably between 1 in 10 and 1 in 20,000 intubations. And they led to 6 deaths, 1 brain damage, and 2 prolonged stays on ITU, probably also with permanent harm. This was one case. I won't read it in full, but it was a patient who had reasons to think they might get anaphylaxis. They were having elective peripheral surgery, and after some airway difficulty, they developed hypoxia and cardiac arrest. Anaphylaxis was suspected. Intubation was undertaken, was a bit awkward. There was a flat capnograph, and this was put down to the loss of cardiac output. You can see that in blue there. So the flat capnograph was ascribed to loss of cardiac output. Ventilation was difficult. This was ascribed to severe bronchospasm, and no action was taken to exclude esophageal intubation. The tube was subsequently found in the trachea. This patient didn't have anaphylaxis. And at the time of the report, the patient was in a persistent vegetative state. This is another case, not in NAP6, some 6 years later. Sharon, who following a polypectomy was extubated and required reintubation and had multiple esophageal intubations, the last of which was not recognized and went into cardiac arrest. Again, the flat capnograph trace was ascribed to the cardiac arrest. She died. Peter Saint was having a knee replacement. He had a laryngeal mask in and had regurgitated. There was an emergency intubation. Again, this was esophageal, unrecognized, despite several members in the team saying, is this esophageal? No action was taken. A flat capnograph was interpreted as being due to cardiac arrest. So we have a flat capnograph. These are inquests from those individuals. A misunderstanding of the physiology and flat capnograph a common issue amongst anaesthetists. So this led to this program, this slogan that came out, capnography in cardiac arrest, no trace equals wrong place. So to emphasize, it's still an important point to make, a capnograph trace is still seen in cardiac arrest. No trace is wrong place. This is a capnograph during CPR, a low, attenuated, but otherwise normal capnograph trace. Now, I recently had to do a cardiocentesis in somebody in ITU who was in cardiac arrest, pericardiocentesis. So we had to see CPR while we did that pericardiocentesis. And so she was in cardiac arrest, but fully ventilated on ITU. And this isn't actually her capnograph trace, I've got it elsewhere. But she continued to have a very normal capnograph trace for many minutes after her cardiac arrest, in spite of no CPR. They've even in Australia taken cadavers out of freezers and ventilated them, not doing CPR, and have a capnograph trace. If you have a flat trace, even in cardiac arrest, you must assume it's esophageal intubation until it's excluded. Did we mention capnography in NAP 4? Well, it's about 200 pages long, 160 pages long. We mentioned it almost 600 times. And we made this recommendation: if a flat capnograph is seen after temperature intubation, the anaesthetist should actively exclude intubation. Teaching should occur. And we mentioned that this occurs even during cardiac arrest. Active effort should be taken to positively exclude obstructed or misplaced, even in cardiac arrest. This problem has been known about for a long, long time. In the closed claims analysis in 1990 in anesthesiology, there was a large number of esophageal intubations, and clinical examination failed to detect these. They were usually preceded by clinical signs of correct position of the tracheal tube. We wrote about it in Anesthesia in 2011. We designed simple ways to teach capnography to non-anaesthetists in 2013, what we call the hats and caps, simple capnography teaching. So I'll come back to that. And this complicated, this busy slide, this is my busiest slide explaining how you analyze a capnograph trace. I'm not interested in any of that. A capnograph trace is not a respiratory monitor, it's an airway monitor. It needs to go up and down, and it needs to be of a certain value. We'll come back to that. But we don't need these complex phase 1, 2, 3, and 4. They're irrelevant for us. So this is our simple way of teaching capnography. We've described top hats and ascot hats, which may not translate, but fascinators. That's the slopey at the bottom left, the ascot hat. These are good. These show that you're ventilating the lungs. And what capnography is a measure of is alveolar ventilation. Whereas if you have a pointy hat, perhaps due to a significant leak, or no hat at all, a flat cap, then you have a bad trace. And this is a good way to teach non-anaesthetists, intensive care nurses, anaesthetic assistants. So in the UK in 2018, for a very short period of time, undetected esophageal intubation, which probably should be called unrecognised esophageal intubation, was considered to be a never event. So that was an event that, if it occurred, had to be reported to the government and specific reports and action taken. That no longer happens, but it was, for a period of time, a never event. I don't like never events, but perhaps we should go back to that system. I'll skip through those. But if we come to the Intube study, which looked at intubation across 29 different countries, 3,000 patients prior to COVID, and it looked at the practices during intubation in this international study, then waveform capnography was only used in a quarter of intubations. I can tell you in the UK, it'd be used in 98 to 100% of intubations. And capnography is your greatest tool, your greatest friend in preventing unrecognised esophageal intubation. I can also guarantee that if capnography was only used in 25% of intubations, then when the patient stayed in ITU and was monitored for a period of time, it would have been used less frequently. This is Glenda Logsdale. She was a healthy mother of 2. She was age 60. She used to work in our health service as a radiographer, and she died from esophageal intubation. So she spent many years working for a health service and then was let down by it in her time of need when undergoing an acute appendicitis, and ultimately she had low-risk surgery and actually a low-risk airway. I won't go into the details of her case, but I will mention one point, which here is that at one point during her management, one individual came into the anaesthetic room and thought he'd seen a normal capnograph trace and therefore didn't think there was a problem with the airway. In fact, what he'd seen was the airway pressure trace and had mistaken that for the capnograph trace. You can see that top trace could be mistaken for the bottom trace and vice versa. And in fact, the capnograph trace was flat in this case. So we could do better in terms of one of the human factors or logistic things we could do is improve. So the college set up the case was reported to the college. There was much unhappiness and sadness and a certain amount of shame about this case. And again, the emphasis was made on no trace, wrong place. But I think we need to move well beyond that. I think we're not in the right place. And this black slide is to emphasize the Glenda Logsdale's death is not the last death in the UK from esophageal intubation. It's not the last death in my region, and it certainly won't be the last death in South America from unrecognized esophageal intubation. There have been many cases, as I've said. I know of the details of about 30 or 40 cases. And from some of those, we get coroner's reports, and we can create a picture of how the sort of anatomy of these cases. And what tends to happen is, going through from top left, we have intubation, which is usually direct laryngoscopy, but occasionally video laryngoscopy, and it's usually considered to be straightforward. A tube is seen going into the right hole. And then there's a flat or abnormal capnograph. And the airway managers decide that there's a good reason why this capnograph is okay in this particular context. They know about flat capnographs because most people do now, but they think on this occasion it's okay. It may be anaphylaxis. It may be bronchospasm. Those are the two commonest causes. It may be another reason. And they then anchor onto the fact, I've seen the tube go through the cord. I know this is in the right place. There's something else going on. What then develops is a clinical crisis as oxygenation fails, as hypoxia occurs. And then there's a lack of structured approach. And what I'll come back to, which is an over-reliance on clinical signs. Help is called for, and cardiac arrest usually occurs at this point. And again, the cause for the cardiac arrest, which is hypoxia, is usually misinterpreted as anaphylaxis, bronchospasm, or whatever anchoring bias is being lent on at the time. Many people arrive. The crowd may be difficult to control. Management is difficult often in a lack of space in an anaesthetic room. In Bath, we anaesthetize everybody in theatre. Somebody will almost certainly say, is this tube in the right place? They may say it repeatedly, and in most cases, the diagnosis of esophageal intubation is considered several times before action is taken. There's an over-reliance, particularly by the intubator, on a history of successful intubation. I know this tube is in the right place. That intubator might check the airway themselves. And there's, in this pandemonium, or this flash team, multiple people coming in, there's an absence of structured response, these common human factors failing in a crisis, loss of situational awareness, and chaos. Many of the inquests describe chaos. And then somebody different from the first intubator tries again, perhaps with a video laryngoscope. Airway intubation is straightforward usually. The airway is almost always secured, but harm has already occurred. And the patient usually dies later, having got return of spontaneous circulation, and inquest follows. They die on intensive care several days later. There's local apology from the hospital, heartfelt local apology. There's local training and local changes in policy. People learn from these tragedies, and the family who can't change the death of their loved one beg that it doesn't happen to another family. So these guidelines which have been developed in about 3 to 5 months with hard work, predominantly by Nick Crimes, Andy Higgs, and I was involved in them as well. They come from the Puma group. I'm not a member of Puma. I was co-opted in to write the guidelines. But they are designed to try and make things safer, and I'll go through their main recommendations. They're supported by many, many organizations, and I think they therefore are international guidelines. These are the principles. It can happen to anybody. We must act safely first. If there's doubt, take the tube out and be happy to take out some tubes that were in the trachea. It doesn't matter. If it's the safest thing, it doesn't matter, and work as a team. So there are 11 principal recommendations. They've been summarized in a nice infographic by Anestesia, and there's a QR code you can use to capture that if you want, but it's widely available on the internet. First recommendation is that monitoring should include capnography and oximetry in all cases. And I think wherever possible, really wherever possible, the capnography should be waveform. The colorimeters, I have a major problem, and Nick Grimes has usefully summarized their limitations. They have lower sensitivity and specificity. They don't give a useful graph. It's difficult to change the extent to measure the extent of CO2 change with just color change. Problems in low output states, problems with low volumes, problems with contamination, problems with tracheal medications. A few of us use those now. Problems in low lights, and problems for some individuals who are colorblind. I would not use them. The second recommendation, use a video laryngoscope whenever feasible. We recognize it's not always feasible, but whenever it is feasible. So I think on the left is a fair representation of many laryngoscopies. And I actually think that we don't create the view of the larynx with a single view. I think the person intubating there will be doing small adjustments of their hand, small adjustments of their eyes, small adjustments of their head to build up a view in their brain, a composite view of their brain of what they can see and where to put the tube. Whereas with videolaryngoscopy, and I've lifted the epiglottis here, so it's not a very good technique, but with videolaryngoscopy, you see that a wide bore, good view airway. Where are these tubes? They're all videolaryngoscopic views, but they're all in the esophagus. Every one is an esophageal intubation. So we also advocate meticulous laryngoscopy. Identify the structures as you go. And in some specialties, so the emergency physicians on the group emphasize that many emergency physicians perhaps feel there's a time pressure to intubate. But actually intubation is somewhere where we should slow down what we're doing. There are other things we can do fast, but intubation requires slow, meticulous, careful practice. So identify the tongue, identify the epiglottis, put the tip into the vallecula, identify the vallecula, identify the cords in the aretinoids, and identify the tube passing within those cords and the aretinoids behind the tube. So the tube between the cords and the aretinoids behind it to confirm intubation has done from a visual perspective. Just to go sideways and talk about videolaryngoscopy, I'll go through this at some speed. So this is my summary of a big meta-analysis by Jan Hansel and Andrew Rogers and the Cochrane Anesthesia group. This updated a previous study. It looked at 222 studies, 26,000 participants, very similar to Carvalho's network meta-analysis, which was published a month or so before. But we divided laryngoscopes into 3 different designs. We accept that they're all different, but I would say that although they're all different, they are all fruit. And this is the summary. So statistically, so everything that is green is statistically significantly better than direct laryngoscopy, and anything that is orange is not. But for the vast majority of these outcomes, with randomized controlled trials, accepting the limitations of RCTs, particularly which look at efficacy rather than safety, then videolaryngoscopes were significantly and importantly and clinically relevantly better. So my summary is videolaryngoscopy is better. And I can say to you, do you want to use a device that reduces failure of intubation, especially in difficult patients, particularly in the hands of trained operators, makes laryngoscopy easier, reduces poor views, improves excellent views, reduces laryngeal trauma and patient sequelae? Do you want to use that routinely? Perhaps more importantly, does your patient want to use that routinely? Or if you offered your patient this and told them you were going to use this, would they want that? And what about, so video laryngoscopy is a better technique. Is it a safer technique? Does it reduce esophageal intubation? So we took the studies that looked at esophageal intubation and looked at them specifically, that included esophageal intubation as an outcome. So this is not unrecognized esophageal intubation, but just esophageal intubation. And so most of them were in theatre. There were very different definitions. But if we look at them, if we just look at the overview, the incidence of esophageal intubation with direct laryngoscopy in well-controlled, randomized controlled studies across all settings is 3%. And with video laryngoscopy, it's 1%. Now, I could just stop there, but we have to use statistics these days. And if you look at all those studies, all combined, then you can see at the bottom that video laryngoscopy is about half, the rate of esophageal intubation is roughly halved, and it's statistically significant because the lozenge doesn't cross zero. If we then divide those into the apples, the pears, and the bananas, those different devices, then only for the hyperangulated blade on the left do we see a statistically significant result. But the lozenges are very much to the left from Macintosh and channeled video laryngoscopes. There you see it again. But perhaps we chose the wrong model, so I won't dwell on this too much, but we use what's called a random effects model, which is it's the lightest statistical test. It's probably the most conservative statistical test. It accepts that there's heterogeneity within the data and both within the patients and within the design of studies, which there was, and it gives conservative confidence intervals. But it's not very good at dealing with events of low incidence. In this case, the heterogeneity of diagnosis of esophageal intubation, then the heterogeneity of the studies is relatively small. So it may have been appropriate to use what's called a fixed effects model, which assumes that all the population studies, they all come from one population as opposed to various populations. Or to use a P to odds ratio, which is specifically better for when looking at low events. And if you do use those different models, with the hyperangulated blade, the lozenge, the confidence intervals changes very slightly, but essentially the effect is similar. There's a 2 to 3-fold decrease, 3 to 4-fold decrease in esophageal intubation with a hyperangulated blade. If you use those other models for Macintosh, then there's it remains a roughly 2 to 3-fold decrease in intubation. In fact, the point estimate is reduced, but it becomes statistically significant. And similarly for channel devices, because that lozenge narrows. Now, we could get very obsessed by this, by the statistics here, but I put it to you that the likelihood of there being harm in terms of esophageal intubation as a result of using a video laryngoscope is close to zero. The point effects and the big picture suggest a 2 to 3-fold decrease in esophageal intubation. And if we use certain models, it shows that all devices reduce it. For me, it's convincing. So we have all these, the meta-analysis has shown that the video laryngoscopes are more efficacious. Are they safer? I think they are. Fewer difficult intubations, fewer attempts, fewer failures, less hypoxia, fewer esophageal intubations, less airway trauma, less musculoskeletal risk to operators, and better inter-team communication, education, teamwork. Those are all safety benefits. But most of the benefits from video laryngoscopy are probably not the technical ones. They're the non-technical ones. There are other people in the room being able to see what's going on. Other people are assistants being able to manipulate the larynx. Other people are being able to see there's an airway problem early on. So this is our airway assistants. They love video laryngoscopes. You have the anaesthetist in this case looking down the airway, doing direct laryngoscopy. But the assistant here is looking at the video laryngoscope, adjusting their cricoid force, optimizing the airway, working out whether they need to call for help or call for something else early on. And again, the same here. So the non-technical advantages of video laryngoscopy are huge. We can supervise airways. We can teach better, with Airways better. Our team understands what's going on. All these tools, these non-technical advantages exist. So we go back to the guidelines, use a video laryngoscope wherever feasible. And actually, we're not the first to recommend that. DAS increasingly emphasised the role of video laryngoscopy in its guidelines. The Canadian Airway Force group recommended in 2021 video laryngoscopy's first attempt, and the UK National Guidance for COVID intubations also recommended video laryngoscopy for all intubations. So my summary is video laryngoscopy is better than direct laryngoscopy. Video laryngoscopy, I believe, is safer than direct laryngoscopy. It's difficult to prove that. It is not a panacea. And then we come to this next big step change, which is the inability to detect sustained exhaled carbon dioxide requires esophageal intubation to be actively excluded. So this is an update from no trace, wrong place. So rather than it requiring a flat trace for us to assume an esophageal intubation, we've moved to dodgy trace, a difficult trace, an abnormal trace, a trace that isn't right, what we call sustained exhaled carbon dioxide. And if we haven't got a good capnograph trace, the default response is to remove the tube, call for help, and attempt ventilation with a face mask or a supraglottic airway. So what this means is that we're saying that some tracheal tubes will be removed. Some tubes that are in the trachea will be removed. There's another reason for the dodgy trace, but we've taken out the tube because it's the safest thing to do. On balance of risks and benefits, it's usually the safest thing to do to take the tube out, reventilate, reoxygenate, and work out what's happening. So it's returning to a place of safety, a place of airway safety, and being prepared to be wrong. So I think that risk versus benefit, the place of safety, and being prepared to be wrong are really important concepts. What is this sustained exhaled carbon dioxide? So that is a trace that rises and falls with inspiration. So rises during exhalation, falls during inspiration, is consistent or rising over a number of breaths, whether it's 5, whether it's 6, whether it's 7, I don't really mind, but it's sustained. The peak amplitude is above 1, and the reading is clinically appropriate. So the peak amplitude above 1, if somebody's in cardiac arrest and they have an amplitude below 1, their chances of survival are very low. If they're not in cardiac arrest and their amplitude is below 1, they're almost certainly the tube is not in the right place. So those are both indications to take the tube out and put it back in for safety reasons. So here we have criteria satisfied. A normal trace at the top, a rising trace, perhaps bronchospasm, which is settling at the top, and then an odd trace, but in the clinical context that perhaps is acceptable. This might be a child with an uncuffed tube with a very leaky tube, but their capnograph is clinically appropriate. And these inappropriate ones, so the top one, which is low and collapsed, just not right. The second one, where the amplitude is decreasing, you're going to put a finger on the pulse and check they're not arresting, which will account for decreasing but not flat capnograph. One that's simply too low, and then one that was the same as the attenuated trace, which was okay. It meets all the criteria, but the clinical context is not right. This is a normal, fit and well, healthy patient for whom the trace is okay. There's something going on wrong here. We need to work out what that problem is. It may not be esophageal intubation, but that's the first thing to exclude. So if you haven't taken the tube out when you don't have exhaled carbon dioxide and the patient then becomes hypoxemic, you must take the tube out. The analysis of risk versus benefits means to take it out. The next recommendation is controversial. The clinical examination should not be used to exclude esophageal intubation. So misting shouldn't be used. Chest rise shouldn't be used. Auscultation shouldn't be used. And I will go through that in a little bit more detail. All my trainees currently say to me, I've got chest rise and misting, I'm happy. I'm going to listen to the chest and check the capnogram. And I tell them all, I don't care about your misting. I don't care about your chest rise. Check the capnograph. Why? Well, what we're not saying is that clinical examination is pointless. We're not saying it has no value. but we are saying it has next to no value in excluding esophageal intubation. And if the capnograph is abnormal, clinical examination adds nothing and will not stop you taking the tube out. You still need to take the tube out. We must understand the limitations of clinical examination. So in the vast majority, I'm not going to give the exact data because it's not been published yet. We hope to publish it. But misting, if the tracheal tube, if there is no misting, you can be certain the tracheal tube is in the esophagus. But conversely, if the tube is in the esophagus, misting is common. In fact, it is more common than no misting. So if it's in the trachea, it will mist, but it's in the esophagus, it'll more than likely mist. And therefore, misting doesn't tell you it's in the trachea. Chest rise, we all have seen the chest rise, because the diaphragm's pushed up as we inflate the stomach, chest rise can be seen with esophageal intubation and gastric ventilation. Auscultation, our ears are not clever enough to discriminate. So we know of multiple cases where esophageal intubation has been preceded by what were heard as normal breath sounds. You hear what you expect to hear, and basic data shows a lack of ability to discriminate those sounds. Just worth mentioning the esophageal detector device. So this is a bulb is attached to the tracheal tube. The bulb is depressed, so some air is pressed into the tube, and then the bulb is allowed to fill or refill. You'll see at the top, at the bottom left with the tick, the bulb has refilled because air has come out of the trachea, and at the bottom right, the air has disappeared down the esophagus and is not refilled. And the esophageal detector device, a simple tool, rarely used and rather out of date, but it does work. At each attempt at laryngoscopy, the intubator should verbalize the view seen. So I've got a full view, the tube is seen passing through the cords. And if you're using video laryngoscopy with a screen, your airway assistant can independently confirm that. The same for capnography. Sustained waveform capnography seen. The assistant, waveform capnography confirmed. Saturations are stable, saturations are good. So what are the circumstances in which you would not take the tube out? I think they include when removing the tube is dangerous. So if you think there's an expectation of impossible or virtually impossible reintubation and mask ventilation and supraglottic airway placement, or there is a very clear and present risk of major aspiration, not every RSI, but a major risk of aspiration, then the tube may stay, and other methods of excluding esophageal intubation be undertaken. These include repeat video laryngoscopy, ideally with two people, both trying to identify the anatomy very clearly. And if the anatomy can't be seen, one option is to put a bougie down the tube, withdraw the tube over the bougie, and confirm that the bougie passes between the cords and the arytenoids can be seen behind it before railroading the tube back in. The other three options are flexible bronchoscopy to identify the carina and trachealis muscle, ultrasound in the hands only of skilled operators who know what they're doing, and the esophageal detector device. And at the same time, a quick check should be undertaken to look for other causes of a flat or abnormal capnograph. Is the circuit leaking? Is the capnograph actually working? Is there a leak around the tube, or is the tube blocked? And other factors. And so there's a checklist to undertake these factors. But if sustained exhaled carbon dioxide cannot be achieved or desaturation occurs while undertaking these tests, still the responsibility is to remove the tube. The risk versus benefit dictates removing the tube. Get to that place of safety, be prepared to be wrong. One but last, standardize and improve the distinctiveness of variable displays. You saw those displays earlier and the mistakes that were made in Glenda Logsdale's case when the airway pressure trace was misidentified as capnography. We think that the capnograph trace should be white and filled in, and we think there should be standardization of monitors. We're speaking to manufacturers about that. Lastly, training. Training is always last, but it's the most important. I've emphasized already that we train as a department, we work together as a department. And because of the emphasis for the first time in all guidelines, so much on the team rather than the individual in these guidelines, it's really important that training is interdepartmental and interprofessional. So this is us going out and about teaching those top hats, flat caps and dunce's caps. These are one of our senior consultants. This is me a few years ago. These are our trainees going into theatre, going into intensive care and teaching people about capnography. People love us doing this, but it's really important. It's fun, but it's got a message. And I come back to that element of institutional preparedness and individual preparedness. So the preparation by the institution controls the potential for individuals to act correctly. And your own ability to respond is determined by your individual preparedness. Neither are very useful without the other. So as examples, the institution must provide equipment and monitoring. There should be policies, training organized. When people come to the hospital for the first time, there should be induction. So I think we can summarize that as the culture, the institutional culture. And for the individual, the core knowledge and skills, knowledge and familiarity of their own environment, making sure you know where you are, what you're going to do if there are problems where you work, and getting involved in local training. And that's summarized as professionalism. So we need the culture of the institution and we need the professionalism of the individual. Neither useful without the other. So going back to Logstell, it's the life of each patient with an artificial airway is dependent on our actions and attention. And I think we do have the tools to eliminate undetected esophageal intubation. As a profession, we can and must do better. So going back to that summary, it can happen to anybody. Safety first. If in doubt, take it out and find a safe place. Be prepared to be wrong and work as a team. And lastly, a couple of slides on things going better. So this is a colleague of mine. He was working in an isolated hospital. He was the only anaesthetist there. There was no backup staff. There's no cardiac arrest team. He was managing a patient who was 150 or 60 kilos. He thought he might be difficult. I said, shall I stay? He said, no. I said, I think he'll be fine. And then I got a call on my phone when I was 20 minutes away. I came back quickly, and here he was. The patient was very safe. You see him here with a ProSeal being ventilated. And Tom had attempted to intubate him with a CMAC number 4. He'd not got any view at all. He'd had only one, perhaps 2 attempts, but there was nothing to change. He was already using the optimum device. He didn't have a hyperangulated blade on that occasion. So he immediately went to a ProSeal, which he inserted over a gum elastic bougie. He fibroscoped down the ProSeal with an airway, with an Aintree intubation catheter to see if he could intubate him through that, got a poor view and decided not to act any further. And he decided to stop, to stay where he was, to stay with the ProSeal in place and ventilate him while help came and he worked out what to do. The patient was woken up and his surgery was postponed. This patient was safe. You could see his airway had been marked before going off to theatre, and he's a little bit hypotensive. The only other aspect of care that I would criticise is the volumes are too high. This is a very effective airway rescue device, a very good seal, a very effective device, ventilating to a peak pressure of 30. So he's slightly over-ventilating him. But boy, he's saved this man very effectively. So there we go. What have we learned from NAP4? Anatomical, physiological, logistical, educational difficulty. We need to remember them all. We need to address and manage anatomical and physiological difficulty. We need to eliminate logistical and educational difficulty. And lastly, this is my friend and colleague who I greatly respect in the top right, Jerry Nolan from the Resuscitation Council, talking about the chain of survival in resuscitation and the American Heart Association chain of survival. Early recognition, early CPR, early defibrillation, and post-resuscitation care, which we all know about and teach. But maybe we need an airway chain of safety, where we are as strong as our weakest link. We start with equipment and monitoring and standards. We have our individual and corporate knowledge. We have effective training as groups, and we have teamwork. So I think we have progressed since NAP4. That progress needs greater reliability and consistency. It also needs action. Several studies have shown that we can improve care by changing, but we haven't necessarily done that. Routine use of an optimal approach is a logical approach, and we need to reduce major adverse events which still occur. This needs to focus on human factors and crisis behavior. Thank you very much.
Fantástico, muchas gracias, Tim, por esta brillantísima presentación que has hecho y que nos ha resumido de manera muy completa los hallazgos del estudio NAP 4 y que hemos aprendido la comunidad internacional con respecto a sus resultados. Me parece que en los conceptos más importantes que ha vertido el doctor Cook nos destacan que el NAP 4 nos ha mostrado que tenemos muchas fallas y muchos elementos, áreas de falla del manejo de la vía aérea que van más allá de lo estrictamente anatómico. Yo recuerdo con mucha claridad el porcentaje de un 40% de fracasos relacionados con los factores humanos, con más de un 80% de fracaso por la mala toma de decisiones que se relacionaban principalmente con la falla en la evaluación y falla en el manejo en equipo. Entonces, todos estos elementos que se relacionan con elementos logísticos también, donde había dispositivos supraglóticos que eran en esa época predominantemente de primera generación. Hoy día la situación ha cambiado y yo creo que puedo tener alguna visión acerca de lo que ha ocurrido en nuestra Latinoamérica, donde también hemos recibido las recomendaciones derivadas de este y de otros estudios y que han producido que nuestra logística, nuestros dispositivos también hayan mejorado en buena parte, sin que ello signifique que en muchos lugares, también un poco alejados de las grandes urbes, todavía existan elementos dispositivos que están alejados de la vanguardia de lo que nos está mostrando la evidencia. Quiero ofrecer la palabra. Primero voy a leer un mensaje que nos envió el doctor Juan Carlos Mandujano desde México, donde él nos habla acerca de que, al igual que en muchos países de habla hispana, nos hemos enfrentado a situaciones de manejo de la vía aérea, no solo con los conocimientos, sino también nos hemos enfrentado a la falta de recursos. Y lo mismo que yo decía en las áreas foráneas, sino también en las ciudades. Y muchos hemos adoptado las recomendaciones de los algoritmos europeos, como el de la DAS, y también por encima incluso de los algoritmos de otras sociedades como la americana. En este sentido, yo creo que muchos de nosotros pensamos que el algoritmo y las guías de la DAS están mucho más cercanas al mundo real que los algoritmos y las guías de la sociedad americana, que pueden ser muy técnicas, pero con nuestras limitaciones en Latinoamérica, donde tenemos una gran población, se nos hace difícil seguir. El doctor Mandujano también nos dice que tu plática es excelente y que nos hace recordar la importancia de la capacitación, el trabajo en equipo y de igual forma el contar con el equipamiento por la parte institucional. Es triste, pero la realidad es que en muchos estados, ciudades de México y también de toda Latinoamérica no se cuenta con un carro de vía aérea difícil para poder solucionar los problemas. Me gustaría que levantara la mano el doctor Ricardo Latrop, nuestro jefe del programa de anestesiología de la Universidad de Diego Portales. Ricardo, la palabra es tuya. Tienes que prender tu micrófono, sí.
Muchas gracias, Ricardo. Primero que nada, felicitar al doctor Cook nuevamente en nombre de la universidad, del programa Anestesia, del Comité de Desarrollo Académico, de la Facultad de Medicina. Muchísimas gracias, doctor Cook. Ha sido un honor y un placer tenerlo. Para nosotros es un orgullo tremendo contar con personas del nivel que usted tiene y en el nivel que ha de alguna manera dirigido, de alguna manera el conocimiento que nos ha permitido mejorar en las últimas décadas. Quiero hacer 2 o 3 observaciones, solamente producto de la plática del doctor Cook. Uno, yo creo que es evidente que en la enseñanza de la medicina, y no solamente de la anestesia o la vía aérea, el tema de seguridad, el tema de pensar en el paciente es absolutamente crítico. Tenemos que enseñar la seguridad como un factor elemental en el trabajo clínico diario de todos nosotros. En ese sentido, yo creo que las guías son eso, guías que nos permiten analizar, a veces con las realidades nacionales diferentes, qué es lo mejor para los lugares donde se está trabajando o hacia dónde va dirigida nuestra enseñanza. Evidentemente con el valor de las guías, que es muchísimo, es un trabajo gigantesco de muchísimos grupos en el mundo. Y entiendo que el doctor Cook es un referente mundial en este tema, por lo tanto los agradecimientos y el honor de tenerlo se vuelven a repetir. La segunda observación es el entrenamiento. La verdad es que durante la charla yo estuve pensando, así como se hacen equipos de RCP en los institutos clínicos, en los hospitales, en las clínicas, probablemente un equipo de enfrentamiento a la vía aérea difícil, especialmente en los pabellones, en intensivo, en urgencia, que tenga capacidad de acudir rápidamente, es tremendamente elemental. Y esto conlleva además el trabajo en equipo. O sea, es importante que el equipo esté entrenado. Ese caos del cual hablaba el doctor Cook, todo lo conocemos en situaciones de emergencia. Y siempre he pensado que cuando uno pierde la calma, pierde el enfermo. Por lo tanto, en ese contexto, creo que el entrenamiento de un equipo que sepa perfectamente qué tiene que hacer, es sumamente importante para el paciente, entendiendo que el grupo humano es el que tenemos que tener claridad de que no se cometan errores humanos. Como dijo Ricardo, de repente la toma de malas decisiones, de repente la falta de entrenamiento, la sorpresa que está eventualmente dada por una mala evaluación. Por lo tanto, es un conjunto de cosas que nos lleva de alguna manera a entrar en la última década al hecho fundamental de la seguridad. Y por último, quiero alabar a la ingeniería en el sentido de la cantidad de tecnología que nos ha permitido mejorar. Tecnología que no tenemos todos en la América Latina, pero que evidentemente tenemos que hacer fuerzas para que tengamos el mismo nivel de seguridad de países desarrollados. Pero en ese contexto, la tecnología es muy importante. Pero yo soy una persona ya antigua en este tema, tengo más de 40 años de profesión anestesiológica y la verdad es que sigue siendo, en mi opinión, a pesar de toda la tecnología que tenemos, el uso de la clínica básica, cuando éramos alumnos, cuando ocultábamos los pacientes, cuando hace 20 años no teníamos estas tecnologías. ¿Qué hacíamos? No olvidemos lo que hacíamos, que nos permitía, si bien teníamos más accidentes, porque evidentemente la tecnología nos ha ayudado muchísimo, evidentemente no olvidemos en juntar la tecnología con la clínica. Los médicos no podemos olvidar la clínica, el ocultar los pacientes después de intubarlos. Si no tenemos una buena capnografía, nos va a poder hacer tomar una buena decisión. El sacar o no sacar un tubo es un hecho complejo, es un hecho de una difícil decisión, por todos los riesgos que el doctor Cook mencionaba. Pero hay una cosa que es crítica: los enfermos de vía aérea difícil se mueren por hipoxia. Por lo tanto, la hipoxia es lo que nosotros debemos evitar. Y uno de los grandes avances que yo he notado en los últimos años es la preoxigenación, la desnitrogenación del alvéolo, que nos permite tener más tiempo de oxigenación apneica. Por lo tanto, esos son elementos clínicos junto a la tecnología que nos va a permitir disminuir los riesgos de los pacientes. Y la verdad es que con todo lo que lamento, el episodio que el doctor Cook relata de una persona cercana a los equipos de salud, la verdad es que tenemos que hacerlo cotidiano. O sea, el hábito, como dijo el doctor Cook, el hábito es necesario, la seguridad es un hábito, no es una cosa excepcional, es un hábito. Quería mencionar eso, Ricardo, fuera de agradecerle nuevamente en nombre de la universidad y de la facultad al doctor Cook y especialmente el programa Anestesia. Ha sido un honor tenerlo con nosotros. Esperamos tenerlo nuevamente este otro año. Ojalá presencialmente en Chile. Estamos planificando cosas, doctor Cook, y usted es una persona tremendamente referente para nosotros. Muchísimas gracias.
Tim, ¿te gustaría decir algo?
Thank you, Ricardo. The pleasure's all mine. So thank you very much indeed. I'm sorry, actually, I had no idea that I'd speak for as long as I did, so apologies. I must have slowed down a little bit, so apologies. I hope there's still some time for a few questions.
Sí, ofrezco la palabra, por favor, a alguno de los participantes que quiera omitir alguna opinión, hacer algún comentario o pregunta. Pues mientras tanto, a mí me quedó muy claro de tu charla, Tim, que hacer un nuevo estudio en App 4 posiblemente no tenga muchas ventajas. Sin embargo, como dije anteriormente, hay elementos que en esa época no estaban totalmente claros, no eran, eran presentes en nuestra conciencia, como eran los factores humanos, lo que dijo el doctor Latrobe acerca del hábito de la peroxigenación, que es la oxigenación durante todo el proceso antes de la intubación, de la evaluación, el manejo de recursos en crisis, que tiene que ver con nuestras habilidades no técnicas y que se refiere al liderazgo, a la toma de decisiones, a la comunicación efectiva, que esos elementos pueden ser posiblemente nuestro norte de ahora en adelante. Nosotros seguimos capacitándonos en el uso de dispositivos, ya sea los laringoscopios corrientes, los videolaringoscopios, los dispositivos supraglóticos. Nos entrenamos en la técnica de cricotirotomía, pero posiblemente poco o nada estamos haciendo con relación a esos factores que tienen una influencia tremenda, especialmente en cómo decidimos seguir manejando una vía aérea que se nos presenta desafiante. Los algoritmos nos dicen muchas veces qué hacer, pero no nos dicen cuándo decidir hacerlo. Por lo tanto, posiblemente esa brecha que sea la que nosotros tenemos en este momento que enfrentar de aquí al futuro, porque la tecnología, tal como dijo el doctor Latrobe, también nos está entregando una muy buena cuota de seguridad en el manejo de nuestros enfermos, ya sea con el uso de los videolaringoscopios, como la capnografía y las técnicas de peroxigenación.
Yeah, yes, I agree, and I think the context is all important. So as I said, I work in a European context. We're relatively affluent. I work in a hospital that serves 500,000 people, but 500,000 affluent people. We're well funded, and in our hospital, we are unique in Britain in having universal videolaryngoscopy. So even within my country, the context of what I say is relatively unusual. We're an unusual hospital to have gone to 100% videolaryngoscopy and to have that very narrow selection of supraglottic airways. But we've made that choice actively. It's not passive. It's an active choice to go down that route. It took us 5 or 6 years of arguing and discussing and cajoling management to get to there. I would never go back. And I think no member of our department, however reluctant in the first place, would go back to the situation we were in beforehand. We've tried to make airway management very boring in our hospital. and boring is good for airway management.
Qué bueno. Doctor Mandujano, desde México.
Hola Ricardo, muy buen día. Una excelente plática, agradecimiento al doctor Cook. De hecho, yo creo que ese conocimiento nos ha llevado a cambiar muchas cosas. Una escala, no sé si haya sido diseñada por él o una modificación a la escala de Cormac, que fue T.M. Cook precisamente, en donde se habla ya del 3A, 3B y las videolaringoscopías que realizó este doctor de 500 propias para poder hacer un análisis sin tantas variaciones, ha sido algo que me ha hecho cambiar muchas formas de abordar al paciente. Al igual que el doctor Latrobe, yo estoy completamente de acuerdo al sentido de que la tecnología debe ser algo que nos ayude, pero que no nos volvamos dependientes de ello, sino que manejemos todos los aspectos clínicos que podamos tener a nuestro alcance. El trabajo en equipo es fundamental, incluso una de las cosas que platicamos mucho con el doctor Marino dentro de estos grupos y que hemos tratado de compartir también con todos ustedes como parte de esta gran familia de manejo de vía aérea, ha sido que incluso debemos ampliarlo todavía más a otras áreas, ¿sí? Tú conoces a Mónica y bien sabes que ella no es una anestesióloga, es una médico urgencióloga que está capacitada en el manejo de vía aérea, o Fuensanta, que es una enfermera capacitada también en manejo de vía aérea, que son otras de las áreas donde el anestesiólogo no siempre estamos presentes y que no podemos estar corriendo a todos lados como en algunas ocasiones se ha aparentemente solicitado. Fíjate que a nosotros acá en México la pandemia nos trajo la situación de que comenzó a haber mayor equipamiento en áreas críticas como urgencias o las áreas de servicios de emergencias. Sin embargo, el factor tiempo que a veces se necesitaba para que pudiéramos prepararnos y acudir al servicio se vuelve algo crítico con el paciente, pero la limitación que había para el personal de urgencias, en lugar de capacitarlos, era no, que venga el de anestesia. Entonces sí necesitamos considerar que este conocimiento de abordaje de vía aérea debe de ampliarse mucho más a otras áreas, a otros compañeros dentro de este equipo, y ya en un momento dado, en algunos hospitales a mí me llegó a pasar que el anestesiólogo solamente llega a corroborar, en un caso de paro, por ejemplo, llega a corroborar que el tubo endotraqueal está colocado donde debe de estar, y ya solamente continúa con el manejo dentro de su participación en la RCP. Entonces, sí es algo que tenemos que trabajar en todas partes y ampliar nuestro conocimiento o difundirlo a otras áreas que nos pueden fortalecer, o incluso acá en México ha habido experiencias donde el personal de enfermería ha mantenido y salvado la vida de un paciente, y cuando llega a un servicio porque le colocaron un dispositivo supraglótico, cuando llega al servicio de urgencias para ya el tratamiento definitivo, se lo quitan y se cae en la desgracia de que ahora ya no puede ser ventilado, no puede ser intubado, y muchos han fallecido. Tenemos unos cuantos casos así comentados por personas, incluso de médicos que estaban maestros de un alto rango y que llegan en esas circunstancias que alguien les puso, un enfermero, un tubo laringio, una mascarilla laringea, lo bajaron al servicio de urgencias y en urgencias se lo quitaron porque esto no sirve, lo botan, que es esa parte de desconocimiento, y cuando tratan de intubarlo, pues se cae en la situación crítica de no poder intubar, no poder ventilar, y médicos que han fallecido que han fallecido por esta falta de conocimiento y de capacitación. Entonces, yo creo que es algo que sí tenemos que pugnar, como es el doctor Latrobe, tenemos que pugnar porque eso sea algo que nos lleve a un mayor nivel de seguridad, pero a nivel internacional con países que tienen este mismo nivel que nosotros estamos buscando.
Muchas gracias, Juan Carlos. El doctor Maceiras, no sé de dónde nos escribe, nos pregunta acerca de qué herramientas básicas debe tener un carro o maleta de vía aérea difícil en un servicio de tercer nivel, sala o planta o emergencia, y cuáles de ellas, por ser difíciles de trasladar o ser muy complejas o muchas veces caras, deberían estar necesariamente incorporados en una planta de, no sé lo que, internación debe ser, o sea, en un área más restringida. Bueno, a mí, si me permiten responder, se me ocurre decirle al doctor Maceiras que posiblemente aquellos dispositivos que le permiten reoxigenar y ventilar al paciente de alguna manera, y que ellos incluso pueden ser manejados por personal no médico, y de restringir o limitar el uso de elementos más avanzados a una situación en la que participen personal médico con experiencia en, por ejemplo, intubación traqueal, ya sea con laringoscopía directa o con videolaringoscopía. No sé si respondo al doctor Maceira o alguien quiere hacer algún comentario.
Hace muchos años, Ricardo, me tocó planificar la unión de, o sea, perdón, una especie de servicio de reanimación en el hospital donde yo trabajaba. Y una de las decisiones difíciles, porque había que hacer una serie de carros de paro o de carros de vía aérea, una decisión difícil fue dónde colocarlos. Cómo tenían acceso a esos instrumentos los médicos en las distintas áreas del hospital, porque no solamente tenemos problemas en urgencia, tenemos problemas en los sistemas de intensivo, o el pabellón habitualmente debería estar esto absolutamente establecido, te fijas, no solamente un carro de paro, sino que un carro de vía aérea difícil, pero muchas veces estas emergencias ocurren en las salas de hospitalización de médico quirúrgico. Por lo tanto, es un tema súper relevante lo que pregunta el doctor Maceiro, en el sentido de dónde deben estar. Y eso es un análisis que tiene que hacer la gente local del hospital donde esto se va a decidir. ¿Ah? ¿Cuáles son sus requerimientos y cuáles evidentemente son los lugares? Ahora, ¿qué es lo que tiene que tener? Yo creo que cualquier anestesista con una formación sólida va a poder ayudar en ese hospital a dar la logística y decir qué cosas tienen que establecerse. Tú hace poco generaste un carro de vía aérea en una clínica donde trabajamos y la verdad es que quedó tan bien hecho, tan estructuralmente bien hecho, que lo hace fácil. Es lo que decía el doctor Cook. Esto tiene que ser fome. No tiene que ser una situación mágica, sino que tiene que ser fome. Tiene que ser tan fácil y el personal entrenado para abrir el cajón correcto, en el momento correcto. ¿Te fijas? Y eso significa, y tú lo hiciste muy bien, significa tener mucha claridad sobre el orden de precedencia en los instrumentos que vas a utilizar en una emergencia. Y yo creo que un anestesista bien entrenado va a tener la capacidad sin duda. Y nosotros en ese sentido, una de las cosas que hizo nacer este webinario y este énfasis en la vía aérea, que Ricardo nos entusiasmó y que Ricardo nos puso frente a los ojos, la verdad de las cosas es que a mí en lo personal me ha enseñado una brutalidad muchísimo en el sentido de la prioridad, la preoxigenación, la tranquilidad, tener los elementos a mano. O sea, yo me siento con una sensación muchísimo más segura, a pesar de los años de experiencia, con una situación como la que Ricardo nos ha ido enseñando a través de estos webinarios con todos los invitados, entre otros la doctora Harber, el doctor Cook y todos los otros invitados que hemos tenido de Brasil, de México, de Perú, de Argentina. La verdad es que esto, y de España, esto ha sido muy interesante. Una gran culminación, de alguna manera, ha sido la presentación del doctor Cook. ¿Ah? Por lo tanto, es muy valioso para la enseñanza de las nuevas generaciones. Es muy valioso el trabajo que se está haciendo por el doctor Cook y otra serie de organizaciones internacionales. Y aquí en Chile, yo en lo personal no tengo duda que el doctor Urtubia es la cabeza del Council también, te fijas, y la cabeza en la cual nos ha metido muchísima enseñanza, muchísimo interés en un área tan fundamental como es la vía aérea para la anestesia. Así que también gracias, Ricardo, porque la verdad es que eso es muy importante.
uno nunca hace las cosas solo, siempre las hace con los amigos como el Dr. Cook, amigos como Juan Carlos, amigos como Carlos Reyes, muchos amigos, todos los que han estado en este webinario, y yo solo he sido puente frente a estos amigos y la comunidad para avanzar y mejorar nuestra calidad y seguridad en el manejo de la vía aérea. Quiero finalmente agradecerle al Dr. Cook por su participación, por su generoso aporte, su generosidad por brindarnos buena parte de su tiempo destinado a descansar un fin de semana para estar con nosotros en esta jornada de webinario. Quiero compartir de nuevo y finalmente mi pantalla para mostrarles, wow, no sé, a ver, algo pasó, no sé qué pasó. Algo pasó, sí puede estar avanzado, ya. Voy a seguir avanzando. Ahí está. Quiero mostrarles desde dónde nos ven en estos webinarios. El año pasado, en el año 2021, ustedes pueden ver todos esos puntitos rojos, algunos más grandes, otros más pequeños, son lugares desde donde nos veían el año pasado. Este año hemos mejorado y ustedes pueden ver, mientras más verde sea el color, más gente nos ven desde todas estas partes. Y realmente nos sentimos muy orgullosos por estar llegando a cada vez más personas que puedan nutrirse de esta actividad que cuenta con grandes expertos mundiales que nos brindan sus conocimientos, sus experiencias, como el Dr. Cook. Estamos también en redes sociales, tenemos muchos seguidores en Facebook, el programa de anestesiología, Universidad Diego Portales también. Tenemos canales de YouTube, ustedes van a poder ver esta charla, este webinario de manera gratuita en nuestro canal de YouTube, canal de Anestesia UDP, y que pueden ustedes acceder a él inmediatamente a través de este código QR que está abajo a la derecha. También en Instagram notificamos nuestros webinarios, en Twitter también publicitamos estos webinarios, y quiero anunciarles el último webinario del año 2022, con el cual culminamos un nuevo, muy exitoso año. Tendremos el grato honor y placer de tener al doctor Hans Witting, de Holanda, de los Países Bajos, que nos va a hablar acerca del concepto de intubación híbrida. El doctor Witting es un colega que realiza una labor educativa muy relevante en Europa, y fue citado en esta charla por el Dr. Cook acerca del estudio, el mini NAP4 que hizo el Dr. Witting en Holanda, y que nos trajo también más información adicional que la que teníamos con el NAP4. El NAP4 ha sido un elemento que ha provocado una verdadera explosión de conocimientos y de avances en los principales conceptos relacionados con la vía aérea. Así es que muchas gracias, Dr. Cook. Realmente para nosotros, para la universidad, ha sido un agrado, un honor poder contar con usted en esta mañana de día sábado, y que nos haya brindado toda esta brillantísima conferencia acerca del estudio tan importante que usted condujo hace un poco más de 10 años atrás. Muchas gracias, Dr. Cook. Bye, bye.
Thank you and bye.
Thank you very much.